Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. It gives me great pleasure this afternoon to introduce you to Rosa Enklaar. She hasn't been with us yet, and it's her first time with us. It's wonderfully welcoming over here, Rosa. You are a PhD student, and the whole idea is that, just hang on a second, there we go. You are a PhD student with Jean-Paul Hoeves, and you are going to be speaking this afternoon about the subject of uterine preserving surgery in prolapse. You've been very kind to say that we are able to, you're able to take questions during the course of your talk, and it's lovely to have you with us this afternoon. Next week, we're going to be talking about progesterones and miscarriages with Professor Arab from Saudi Arabia. We like, in fact, to have a wide variety of speakers in obstetrics and gynecology from all around the world. And as you can see, we have experts. We've sourced experts from all around the place. And Rosa, it's wonderful to have you this afternoon. We look forward greatly to having you on our webinar. And if you could share your slides, it'd be wonderful. Thank you very much indeed, Rosa Enklaar.
Thank you so much, Peter. I will start sharing my slides. So I think right now you can see my screen. If I'm
certainly
correct.
Can, Rosa.
Perfect. So good afternoon to you all. And I would like to take this moment to thank you for the opportunity to present today. Let me see. First, I would like to give a short introduction of myself. I'm Rosa Enklaar. I'm indeed a resident in the Obstetrics and Gynecology Department in Den Bosch, or 's-Hertogenbosch, in the Netherlands. And last year, I've completed my PhD in the Radboud University Medical Center, and my dissertation was last May. As you can see here, I am part of the some research group, and my PhD dissertation was about uterus-preserving surgical treatment for uterine descent, with the focus on sacrospinal hysteropexy and the Manchester procedure. And over here you can see my thesis. So today I would like to take you along the subjects of my dissertation. And first, we have a short introduction of pelvic organ prolapse. I will tell you something about the treatment options, how prolapse is treated in the Netherlands. I would give you the perspectives of the Dutch patients and the gynecologists. And at last, I would like to discuss some studies regarding pelvic organ prolapse. So first, as a disclaimer, this presentation, the numbers I mention are applicable to Western population and as we have here in Europe, or the Dutch population. So what we see in the Netherlands is that there currently are about 40,000 patients referred by their general practitioner to the gynecologist for prolapse or urinary incontinence complaints. And the lifetime risk to undergo pelvic organ prolapse surgery is between 11 and 20%. So most patients who are operated are between 60 and 70 years of age. And we see that the most common stage of prolapse is prolapse stage 2. And it occurs in about 50 to 60% of the women with a prolapse. To start, I want to mention the different types of pelvic organ prolapse in women with prolapse complaints. The most common type of prolapse is the anterior compartment prolapse, or the bladder, which is also called a cystocele. You see that on this, I don't think if you see my cursor, but it's the second image. So most often there is a combination of several compartments. We have the anterior compartment, or the bladder, the middle compartment, or also called the apical compartment, which is the uterus, or can also be the vaginal fold in case of a prior vaginal hysterectomy, or the posterior compartment, which represents the bowel as well. Many women with pelvic organ prolapse are asymptomatic and they do not require treatment. But women who develop symptoms may present with a single symptom, such as vaginal bulging or pelvic pressure, or sometimes they also have multiple complaints. And what we know is that the hymen appear to be an important cutoff point for symptom development. And this is particularly true for women with prolapse that is mild, and it does not extend beyond the hymen. But when the leading edge of the prolapse extended beyond the hymen, the number and the levels of the complaints do increase. So, for the treatment of pelvic organ prolapse, we have several options. At first, it's important, of course, to discuss with the patients if the experienced complaints are severe enough compared to the treatment with possible risks or disadvantages of the treatment. And the least invasive option is, of course, to wait and see. And also in the stage of treatment, lifestyle changes can be implemented, which can help to prevent worsening of the prolapse. So next are conservative options, which are pelvic floor therapy to strengthen the pelvic floor, or pessary therapy. Sorry. And
Rosa, can I just interrupt? What
yeah,
lifestyle changes do you suggest would be profitable in women that have symptomatic prolapse?
Well, to start, I think weight loss, because a high body mass index or high weight is one of the most common risk factors for developing prolapse, and I think that weight loss is really helpful to prevent the prolapse from getting worse, but also for your whole health, it's better to lose some weight. Yeah.
Okay. Does smoking make the prolapse worse or not? There's another question.
Well, that is interesting because there has been a risk factor analysis by my colleague, and there in the results showed that that smoking was not a risk factor for developing a prolapse, but we don't know really why that is that way. And you can imagine that if you're a heavy smoker and you're coughing a lot and there's a lot of higher abdominal pressure, that would be a risk factor to develop prolapse. So I think it's a bit of both and it's multiple causes, yeah.
All right. Talking about causes, I don't want to interrupt you too much, but I keep getting these questions. It's famous that Dutch women have lots of vaginal deliveries, particularly at home. Do you think that vaginal delivery at home predisposes towards the highest, very high incidence of prolapse in Dutch women? 40,000 sounds like a lot of referrals.
It is a lot of referrals, and but it's also urinary incontinence complaints, so it's a bit of both. But I think that vaginal delivery, and especially with a larger child, and I think that the Dutch population is also known for bigger children,
That's true.
is also a risk factor for developing prolapse. I'm not sure if home delivery is a risk factor. In fact, I do think that when you're delivering in the hospital, there is also a chance that you might undergo a vaginal assisted delivery, which can also be a risk factor for developing prolapse.
So is cesarean section in that case almost by definition protective against prolapse?
Yeah, but it is still a big operation, and I'm not sure if it will helpful to give all the pregnant ladies a cesarean section to prevent them from having prolapse. And also, it is not the case that if they do have a cesarean section, that they do not develop a prolapse later on in their life, because there are also other risk factors. Yes.
Thank you.
Okay, shall I continue?
Please continue.
So I think we were with the surgical options, and the type of surgeries depending on the type of prolapse you have. As you can see here, we have the anterior colpography for the anterior wall, anterior vaginal wall prolapse, and we also have the posterior colpography. And for the apical compartment, we have uterus-preserving surgery or hysterectomy, and most often there's a combination of one of the anterior or posterior colpographies with a middle compartment. Today I'm gonna talk about uterus-preserving surgical techniques, and will have a main focus on two techniques, and that will be the Manchester procedure and the sacred spinous hysteropexy. And in the Netherlands, these two techniques are most often performed in patients with uterine descent. So what we see in the Manchester procedure, it is actually a technique which is performed for quite a long time. And it includes a fixation of the uterus to the uterosacral cardinal ligaments, and also includes an amputation of the cervix. As you can see in the right image, you see the cervix is a bit blue, and that's the part which will be amputated. Also, we see the sacral spinous hysteropexy, and it is globally often executed for the correction of vaginal fold prolapse, but is also performed to lift the uterus by fixating it to the right sacral spinous ligament. So it's a unilateral fixation. And later on in this presentation, I will elaborate a bit more about these techniques. And if you'd like to read a more detailed description of both techniques, I would like to refer you to the supplementary material of our publication in JAMA of the SOM study. I will later explain that as well. But you see in the left corner, you can see the code, you can find it. So for now, I want to tell you something about the treatment of uterine descent in the Netherlands. And on this slide, what we see is a number of surgeries for the uterine descent per technique plotted out over the years. And as you can see, the number of surgeries for pelvic organ prolapse has increased. And this might be because of the increase of body mass index, but also of the aging of the population. And what we also can see is that the number of vaginal hysterectomies has decreased. That's the white dotted line a bit in the middle of the figure. And down in the figure, you see the arrow, and it points out the number of Manchester procedures, also called cervical amputation, and it has slightly increased. So on the previous slide, I showed you a bit older data, but the changes are also noticed in the years thereafter. So before we go there, I need to explain some things about the healthcare system in the Netherlands. In the Netherlands, healthcare insurance is mandatory, and all invoice data given to health insurance companies are based on healthcare declaration codes. And each medical condition has a specific declaration code developed by the Dutch Healthcare Authority. And the official nationwide healthcare code for pelvic organ prolapse and urinary incontinence, they're both together, is G25, which you also can see on the slide. And within this healthcare declaration code, conservative treatments and surgical procedures for both pelvic organ prolapse and urinary incontinence performed by gynecologists are registered. And for this study, we have analyzed data of 50 Dutch hospitals in 2011 and 2017. And we have looked at the number of new patients registered in a G25 declaration code. We noticed that the number of patients who were referred to the gynecologist has decreased from 28,000 to 23,000, which is a decrease of 16%. The number of prolapse surgery has decreased from 9,500 to 6,400, which is a decrease of 17%. And what is actually a striking finding is that the number of vaginal hysterectomies has decreased from 2,600 to 1,200. And we can conclude that there are less surgeries performed, and that there's an increase of uterus-preserving surgeries.
Rosa, if I can just ask you, that's the slide I want you to look at. Why has the number of hysterectomies, vaginal hysterectomies in that case, diminished so dramatically, more than 50% in only 6 years before COVID?
Yes. Well, I will explain a bit later as well, but I think that it was indeed before COVID, but there were some studies published, I think about 2015, and there was a Savior trial. I will discuss this later on in this presentation, and it made the comparison between vaginal hysterectomy and uterus-preserving surgery, the sacred spinous hysteropexy. So in that study, there was for signs that preserving the uterus was a bit better, and patients also like that. But I will discuss it because it was a bit. I will explain it during the presentation as well, I think.
Okay, I'm sorry, I didn't mean to interrupt.
It's okay. So we go to the next slide. Because I also want to talk to you about practice pattern variation. And this is a bit difficult. It reflects the differences in care that cannot be explained by the underlying condition. And it can also be caused by, for example, the lack of evidence and therefore the lack of evidence-based standards and also difficulties in counseling the patients. And also a difference in skills and resources or the preference of the surgeon plays a role in this. And practice pattern variation can lead to under and over treatment and therefore could introduce an unnecessary risk of medication or surgery, or patients might not receive adequate treatment for their medical condition. And also it is associated with unnecessary high healthcare costs. So that is something we have to work about, I think. And in this study, we've also analyzed the differences in practice pattern variation in the Netherlands between those 2 years, so 2011 and 2017. And we have looked into the data of prolapse surgery and vaginal hysterectomies. And in both categories, we saw a significant reduction of practice pattern variation. And this means that the number of different types of surgeries has decreased. So the hospitals are doing more the same procedures. And the question is what also was your question, Peter, if we have an explanation for this practice pattern variation, but also for the decrease. And in the Netherlands, it took until 2014 for the first guideline for management of pelvic organ prolapse to be published by our Dutch Society for Obstetrics and Gynecology. And in this guideline, it said that conservative treatment is considered to be the first choice of treatment for pelvic organ prolapse. This guideline stated also that there was not enough scientific evidence to show a difference in recurrence rate between uterus-preserving and uterus-removing surgery. So everybody did what they like.
So it doesn't make any difference if you leave the uterus or conserve the uterus to the outcome of the prolapse surgery. Is that what you're saying?
No, at that point they did not. Yeah. Okay. So there were when they make the guideline, there was not enough scientific evidence to prove that uterus preserving surgery was better than uterus removing surgery. Okay. So their statement was, we don't know actually. So yeah, good luck. Yeah. But that's why we did a few other studies. And also in 2015, several studies, not only in the Netherlands, but also studies from Denmark are published. And these studies have shown that the sacred spinous hysteropathy and the Manchester procedure, which are uterus preserving surgeries, are at least non-inferior and possibly have some benefits in longer follow-up compared to the vaginal hysterectomy. And it's plausible that the guideline and the growing scientific evidence for uterus preserving techniques have contributed to the reduction of practice pattern variation, but also in the reduction of the number of hysterectomies, as you asked me about. So what I was also interested in was the opinion of Dutch gynecologists, because one of the the causes of practice pattern variation is the preference of the gynecologist. So we wanted to determine the thoughts and consideration of them regarding the two most often performed techniques. And therefore we have executed this qualitative study. And we have interviewed several Dutch gynecologists to discuss the advantages and disadvantages of the most two common techniques. And on this slide, what you can see here are some of the advantages and disadvantages which are mentioned in the interviews. And as you can see, there are several arguments which are similar for both procedures. So both procedures were described as tough, as easy procedure, so it's a bit conflicting, but it depended on the preference of the gynecologist which was which. And also in both techniques, dyspareunia was considered to be a disadvantage. And we have also looked at the decision-making process. preoperatively, it turned out that the decision was mainly based on the experience and the background of the gynecologist in combination with the experience of their older or more experienced colleagues in their team. Also, patients-related factors were, of course, important. And also a striking finding is the variation of the explanation of surgical options towards the patients. So in 70% of the interviewed gynecologists, their explanation was focused on the technique of their own preference, and they would not mention the other one. So that might also be a consequence of the lack of evidence. But besides the preference of the gynecologist, it is also important to look into the preference of the patients, because they also have an opinion, of course, when it's their body. And in this study, the patients' preferences were examined regarding uterus-preserving surgery and vaginal hysterectomies. And it shows that 43% of the women had a preference for uterus-preserving surgery, which increased towards 65% after counseling the patients about the procedures. My colleague also did a patient preference study, and there she examined the preferences of Dutch patients regarding the uterus-preserving surgical techniques. And these women were asked to choose one of the techniques in several different scenarios. And the difference in the scenarios were based on different levels of success, of treatment success, dyspareunia, cervical stenosis, and severe or persistent buttock pain. And what we saw is that of the 98 patients who participated, the preference was almost equally divided between the two procedures. 47% chose the sacred spine and hysteropexy, and 53% the Manchester procedure. And some women told us that the choice was very difficult to make because of the similarities between the two procedures. And we can conclude from this study that it's a good quality counseling and that can help, and including the previous mentioned factor. So, Peter, does that answer your question a bit?
Yes, thank you very much.
Okay, perfect. Well, let's continue, because now we have discussed quite a lot already. But I want to discuss two Dutch trials with you regarding prolapse surgery. The first one is the SAVIOR trial with 1 year follow-up and 5 year follow-up, and the other one is the STEM study. Let's begin with the SAVIOR trial. In the SAVIOR trial, the comparison was made between sacred spine and hysteropexy and the vaginal hysterectomy. And in this trial, patients were randomized between two techniques. A total of 208 patients were included, and all patients had uterine descent stage 2 or higher. And there were 4 Dutch hospitals participating, and the follow-up was 5 years in total. So the primary outcome was surgical failure of the apical compartment, and this included current stage 2 prolapse or higher in the apical compartment in combination with bulging symptom or operation for recurrent prolapse of the apical compartment. And also the secondary outcomes were anatomical failure, composite outcome of success, which included no prolapse, no bulging symptoms, no reintervention, the quality of life, of course, and sexual functioning. All outcomes were analyzed using the intention to treat methods, and the surgical failure and composite outcome of success were also analyzed using the per protocol analysis. A last observation carried forward analysis was used for the missing data, and at last, a time to event survival analysis was performed after 5 years. Let's have a look at the results after 5 years, because after 5 years of follow-up, 4 patients was available for analysis using the last observation carried forward. And the top Q scores of 81% of the patients were available, which I think is quite a high number after 5 years of follow-up. So that is really good. As we look at the baseline characteristics, we see no differences in those characteristics between the two groups. In both groups, 2/3 of the patients had a stage 2 prolapse. After 1 year follow-up, the sacrospinous hysteropathy was non-inferior in comparison to the vaginal hysterectomy for the primary outcome and surgical failure of the apical compartment. There were no recurrent apical prolapses with building symptoms or with a reoperation for the sacrospinous hysteropathy group. However, in the vaginal hysterectomy group, there were 4 patients. And there were no differences in secondary outcomes. So the patients were followed up to 5 years, and we see here the 5 years results. And we see that surgical failure of the apical compartment, which was a recurrent prolapse stage 2 or higher, combined with bulging symptoms or reoperation, did occur in both the sacrospinous hysteropathy group as well as in the vaginal hysterectomy group. However, we see a difference that the difference is now almost 7%. If we compare this to the results at the outcome of 1 year follow-up, the difference between the two procedures has increased from 3.9 to 6.7% in favor of the sacrospinous hysteropathy.
Sorry, just go back a bit there, please, Rosa.
Yeah.
So intention to treat. So I just want to know statistically, is there any improvement in the outcomes for sacrospinous hysteropexy versus vaginis? I see the difference, but I want to know if it's statistically significant, because it looks to me that in terms of the ITT analysis, it crosses one, so there's no improvement statistically in the one over the other one. Am I right or wrong?
No, there is because it's below 0. Because it's
below 0, but it does cross 1.
Yeah, but that's in this analysis is not. I think it's a statistically significant difference.
Is it?
Yeah, I thought
so. All right. Okay. Thank you.
If we zoom into the results of the different compartments after 5 years preoperatively, we can postoperatively, we can conclude in recurrent prolapses in the anterior compartment. However, what we see in the posterior compartment is a bigger difference. This difference did occur despite more women received posterior colpographies in the vaginal hysterectomy group. And what we also saw in a secondary risk analysis is that the odds ratio was found for 5.46 for prolapse recurrence in a posterior compartment up to 5 years after the initial operation.
Right.
And what we see here is the composite outcome of success. We see significant difference in favor of the sacrospinous hysteropathy, and which is 89 patients with a success 5 years post-operative versus 77 patients after the vaginal hysterectomy.
What is the relative risk in that line of the ITT analysis there?
Sorry, what did you mean?
Looking at the statistics, I see the difference is 11.5%. Yeah. But what would that be in relative risk, or what is the other measure you used? Not relative risk.
Odds ratio?
Odds ratio, yeah. What is that?
Yeah. I'm not sure by head right now. I have to look that up for you.
Okay, yeah. Thank you.
What do we have here? Oh, yeah. So we have also the per protocol analysis, right? We just discussed the intention to treat analysis and now the per protocol. And as you can see, they're still in favor of the sacrospinous hysteropathy, but these are not statistical significance. So
thank you.
And when we look at repeat surgery, there was no significant difference in repeat surgery after 5 years between the two groups. And there was also no significant differences in groups regarding the quality of life. We also did the sexual functioning with the questionnaire, the PISQ-IR questionnaire, and we noticed a significant improvement in both groups, but there was no difference between groups.
Okay.
And all the survival analysis we performed did not show any differences. So
Thank
can
you.
we conclude from this? We can conclude that in this study, the sacral spinous hysteropathy is more effective in the long term, so 5 years post-operative, compared to the vaginal hysterectomy. And we found no differences in any other secondary outcomes. Also interesting, the cost effectiveness. What we can conclude based on several studies regarding cost effectiveness of these two procedures is that the sacral spinous hysteropathy is cheaper compared to the vaginal hysterectomy. However, the vaginal hysterectomy is more cost effective regarding the postmenopausal blood workup. So that's something you might want to take with you in your counseling. But what we see in the data of the SafeU trial, it shows us that the sacral spinous hysteropathy is more cost effective than the vaginal hysterectomy. So let's continue to the SUM study. And this study was also part of my PhD. And this study was a randomized clinical trial which included 434 patients who were randomized between the sacral spinous hysteropathy or the Manchester procedure. And patients who were included in the study had a symptomatic prolapse with the uterus still there, and the POQ point D was minus or was at -1 centimeter. We had 26 Dutch hospitals who participated, and these results are about the 2-year follow-up. So I will quickly explain the two techniques as we used in this study, and also the more detailed description you can also find in the supplementary material in the publication of the study. And what I mentioned before with the sacral spinous hysteropathy, you see that the uterus is fixated to the right sacral spinous ligament. And during the study, the surgeon could choose how to place the sutures. It could be open under direct vision by using retractors and long needle holders, or it could be by using a suture capturing device. The distribution in this study between the open technique and the suture capturing device was 50%. During the Manchester procedure, the uterosacral ligaments are plicated posterior to the uterus, and the superior suture runs through the vaginal epithelium of the posterior fornix. And the cardinal ligaments are plicated and sutured to the anterior side of the uterus. Furthermore, an amputation of the cervix was performed, which you also can see in the image. Our primary outcome was a composite outcome of success, which was defined as the absence of pelvic organ prolapse beyond the hymen in any compartment, the absence of bothersome bulge symptoms, and the absence of prolapse retreatment, such as pessary therapy or surgery, within 2 years after the operation. The secondary outcomes were anatomical outcomes based on POPQ, perioperative outcomes, questionnaires, and costs. This study was based on a non-inferiority design, and the success rate for both operations was set at 89%. The non-inferiority margin was set at 9%, and this was all based on other prolapse studies. And
Rosa?
Yeah.
Sorry, can you just go back one slide for your outcomes?
Yes.
Was there any quality of life question? That's a secondary outcome, was it not a primary outcome?
No,
Okay.
it's the quality of life was included in the questionnaires. Yeah.
As a secondary outcome. Okay, thank you.
Yeah, it was. We included, I think, 8 different questionnaires. It was quite a lot. Yeah.
Okay, thank you.
So the composite outcome was a non-inferiority design, and had to be proved in both the intention to treat and the per protocol analysis. So starting at the baseline characteristics, there are no differences between the two groups. And what we see, the typical patients who participated in this study is around 60 years of age, and 2 vaginal deliveries, typical Dutch perhaps, and also a body mass index of 26. And most women in this study had a stage 2 apical prolapse preoperatively, and the anterior compartment was most often beyond the hymen. Well, let's have a look at the other results. We see that more than 90% of the participants received an anterior colpography and 1/3 received a posterior colpography. It was concomitant surgery, so it was next to the Manchester or the sacral spinous hysteropexy. And there were no differences between these two groups. So the primary outcome of the study was the composite outcome of success, which was defined as the absence of pelvic organ prolapse beyond the hymen in any compartment, the absence of bothersome bulge symptoms, and the absence of prolapse retreatments such as pessary treatment or surgery. And what we see here is that there is a success in 77% of the patients after the sacral spinous hysteropexy, compared to 87.3% of the patients after the Manchester procedure. And in both the intention to treat as the per protocol analysis, the difference between the two procedures is more than a non-inferiority margin of 9%, which we had set prior to the study. Because the difference in success between the two procedures was more than 10%, and we had decided prior to the start of the trial that every difference above 9% was relevant, we can conclude from this study and these results that the sacral spinous hysteropexy is a less effective procedure for the treatment of uterine descent. So it's also interesting to look at the different subcomponents of the composite outcome of success. As you can see in this table, only the subcomponent of prolapse beyond the hymen is statistical significant. So that would play the biggest part in the difference between the two in the composite outcome. As we have a look at recurrent prolapse in the anterior compartment in all compartments, we see that in the anterior compartment it occurred significantly more after the sacral spinous hysteropexy as compared to the Manchester procedure. And this also corresponds with the results we see of recurrent prolapse beyond the hymen and the number of repeat surgeries. When we look at the posterior compartment, you see that there are significant more recurrences after the Manchester procedure as compared to the sacral spinous hysteropexy. However, if we check these results in data of recurrent prolapse beyond the hymen, I will show you next, this difference between the groups disappears. So this implies that the recurrent prolapse in the posterior compartment is less severe than the one in the anterior compartment. So as you can see here is recurrent prolapse voorbij is beyond the hymen. And in this table, you see that there is only a significant difference left in the anterior compartment, as you can see. When we have a look at the repeat surgery in a compartment which was operated during the initial surgery, it occurred more often after the sacral spinous hysteropexy. And if we look at reoperations in non-operated compartments, there were some differences, but they were smaller and not significant. The bothersome bulge symptoms were in both groups similar at 2 years follow-up. And also when we have a look at the bulge symptoms without any re-intervention, we see also that there is no significant difference. The perioperative results. We did not find any differences between the two procedures when looking at the operating time, estimated blood loss, or the length of hospital stay. And we also did not find any learning curve effects in the operating time. As previously the gynecologist said that depending on their preferred procedure, the other one was difficult to learn. So it would not have surprised us if we saw it in these results, but we did not. So we can conclude that both the procedures are easy to learn, and if you're a bit good at operating and familiar with the anatomy. So let's go to the complications.
Rosa, can I just interrupt just before we get to complications?
Sure.
You just said that both, perioperative, both are easy to learn. Can I just ask you, in terms of surgical prolapse, surgical preference, which is your preference between those two operations?
Well, I have to be completely honest because
Be completely honest if you don't mind.
I haven't do not have that much experience in the operating room, so um, I have to look at my colleagues and my research team who are operating more often than I have because I'm just starting my residency and I'm going to learn these techniques. So I will, in a few years, I can tell you which one is my preferred technique. But what I hear from my colleagues is that when you know how to do a vaginal hysterectomy, you can also do a Manchester, or when you know the anatomy in the pelvic area, then you can do these procedures.
Okay, thank you. Thank you for being honest.
So the complications, I said here the specific complications after these procedures. So those are buttock pain after the sacral spinal hysteropexy and cervical stenosis after the Manchester procedure. And in 2% of the patients, severe buttock pain did occur, which was treated with removal of the sutures or nerve block placement. And cervical stenosis occurred in 2 patients after the Manchester, and 1 patient developed an hematemetra, and she was also premenopausal. And during the study, we did not screen for malignancies of the uterus, but we did not see any events appearing during the follow-up. And also what we see in other studies, for example, a big database study from Denmark, is that the risk of malignancies after uterus-preserving surgery is very low. It's about 0 to 1.1%. So I think that it's safe to say that you can do you can perform uterus-preserving surgery and do not have to fear for those complications. But you have to be careful, of course.
What screening did you just repeat that thing about screening for cancer?
We did
What
not
did you say?
screen.
You didn't? Well, what about pap smears?
Well, we did pre-operatively, the pap smear has to be right. And if the endometrium was too thick, we also have to do a sample. So everything has pre-operatively, I would also recommend to do that. So because you are fixating the uterus, so you have to be sure that the endometrium is fine, that the cervix and the pap smear is all right. But during the surgery, during the follow-ups, I'm sorry, we did not screen for any malignancies, but we did screen for extra visits outside of the follow-up visits, and they did not occur.
Okay, thank you.
For malignancies. So that is why it's safe to say that we know that we're almost certain that there are no malignancies, and it also corresponds with the findings in other studies. Yeah.
Thank you.
So short patient reported outcomes. So as I told you during the follow-up, we've sent several questionnaires to the participants. And here I show a section of the patient global impression of improvement questionnaire. And in this part, we made the PGII success. And we included both the patients who reported they had much improved and very much improved situations 2 years post-operative. And you see, as you can see, it's not statistical significant, but it is similar in both groups. So for now, I have discussed 2 important Dutch studies regarding the treatment of uterine descent, but it's important to see if we can compare the results. So looking at the results of the SAVIOR trial, this is the first trial I told you about, we see that the sacral spinal hysteropexy has similar results as the Manchester procedure in the SAM study. But if we look at the results of the sacral spinal hysteropexy we can see that this procedure was performing better in the SAVIOR trial compared with the Manchester procedure in the SAM study. There are also some differences between the 2 studies, which might contribute to these findings. In the SAVIOR trial, only 4 hospitals participated instead of 26 in the SAM study. In the SAVIOR trial, all sacral spinal hysteropexies had an open approach on a direct vision, which was 50-50 in the SAM study. And also there was a difference in inclusion criteria. So in the SAM study, we had POCU point D, and in the SAVIOR trial, POCU point C. And in the SEM study, we have chosen for the POPQ point D because the patients who participated in our study had a mild to moderate uterine descent, and also we wanted to include the patients with a slightly elongated cervix, and they were included this way as well. As we saw, the higher percentage of the anterior compartment recurrences, which were noticed in the SAVIOR trial after the sacrospinous hysteropathy, are also found in the SEM study. Also, we saw that the posterior compartment after the sacrospinous hysteropathy performed better compared to the posterior compartment after the vaginal hysterectomy. And this is also applicable to the Manchester procedure to a lesser extent. So what we might conclude is that we have to pay attention to the posterior colporrhaphy in the Manchester procedure. So what do we do now after we know these results? Well, in the Netherlands, we are now updating the Dutch guideline, and we want to include the previously mentioned studies as well. And of course, we are also focusing on the long-term results of the SAVIOR trial with a follow-up of 10 years at this moment, and also the 5-year follow-up of the SEM trial is going on. I did not tell you about the cost effectiveness yet because we have an article pending about it. So I hope that we can share those results really soon. But I think what most important is right now is that I hope with this presentation that I can create more awareness for the uterus preserving techniques and especially the Manchester procedure. So the take-home message of today, uterus preserving surgery is more upcoming. Sacrospinous hysteropexy has good long-term results compared to the vaginal hysterectomy, and sacrospinous hysterectomy is inferior to the Manchester procedure.
Rosa, just go back because lots of people are taking photographs of your take-home message. So uterus preserving surgery is gaining in popularity, shall we say?
Yeah.
And then sacrospinous hysteropexy, good long-term results compared to vaginal hysterectomy.
Exactly.
So outcomes are favorable. All right. Yeah. I'm just writing this down for our questionnaire. Favorable versus vaginal hysterectomy. And then sacrospinous hysteropexy is slightly inferior to Manchester procedure. Would you say that?
I will leave this slightly.
You just say it's inferior.
Yeah, because it's a 10% difference, and I think it's quite a lot.
Okay. All right. That's wonderful. And I thank you very much indeed for your presentation.
Yeah, thank you so much.
So, could I just ask 1 or 2 questions? Would you mind?
Yeah,
there
sure.
is a bit of time. The first question is this. Why do you think Dutch women are entertaining the possibility of uterine sparing procedures more now than in the past?
I think right now they feel like they have a choice themselves, so they have the feeling that they can make the decision, and also I think that a more upcoming consideration is that they want to keep their body as it was and leave the uterus in place as well.
Okay, so they want to preserve their bodily image, would you say?
Yeah. Yes.
Do you not think, if I may play devil's advocate, that the type of surgery depends on the surgeon's preference rather than the patient's preference in terms of the way the surgeon explains the operation and outcomes?
Yes, I think that's really good that you say that, because I think that right now it's more depending on the surgeon's preference, but it should go a bit more to shared decision making and a bit more in between both, because I think the patient also have to say something in the process of making the decision, but the gynecologist or the surgeon has to inform the patient, and not only in one procedure but in the several options that are available.
Yeah. Okay. Well, that's wonderful, Rosa. I'd just like to remind there's over 100 people logged on and that have enjoyed your presentation, wonderful outcomes, and they would all like to thank you very much indeed, and I'd like to second that. Secondly, to remind all the people logged on that in October this year is the FIGO meeting in Cape Town, and everybody is welcome, and I hope that you and your friends from the Netherlands will be able to be with us over there. And then the final thing is just to remind all those people that wish to hear next week's talk, which is the use of progesterones in miscarriages by Professor Arab of Saudi Arabia, of course. We would like to welcome you then. So then I'd finally like to thank our technician, Nadir, very much indeed for all his efforts and in making this presentation run so smoothly. So Rosa, all the very, very best. And we wish you very well. We wish you very well in your clinical apprenticeship coming up in the Netherlands. All the very best. Safe home. And we see you over here, same time, same place next week. Good night, Rosa.
Good night. Bye-bye.
Bye-bye.